Welcome everyone. We are live and recording. Darian's streaming from our Instagram live on the @Carolina Union Instagram handle. So we'll be taking questions that are submitted live through Instagram, but we're also I've connected with our three awesome panelists already ahead of today's Zoom session, and we'll be covering some pre-submit questions that have been coming in throughout the week for our panelists specifically with regard to topics that cover COVID-19 and also information about their healthcare professions and where they're going in life and how they've ended up where they are today. So without further ado, I'm going to kick over our conversation first to Amy Wisdom.
Hey guys, my name is Amy and I'm a 7th year MD PhD student at Duke. I grew up in Northern California and then I went to undergrad at UCLA. And so when I was there, I started doing research in the neuroscience department, studying multiple sclerosis and other neurodegenerative diseases. And then when I applied to my MD PhD programs across the country, I ended up coming to Duke specifically for their neurobiology department. And actually I ended up doing my first 2 years of medical school and then doing my clinical rotations. And what I realized was that I really liked working with cancer patients. So I just completed my PhD in cancer biology here at Duke. And I have 1 year of medical school left. And I'm happy to talk to you guys about applications to PhD programs, MD programs, or combined programs.
Thank you, Amy. Let's hear from Bill next.
Hi everyone, my name is Bill Wilson. I am currently an infectious diseases and antimicrobial stewardship pharmacist at UNC Medical Center. I primarily practice in the Children's Hospital, but I also have responsibilities in the rest of the healthcare system. I originally grew up in Kansas. I went to undergrad at the University of Kansas. And after 2 years of prerequisites, I went right into pharmacy school at the School of Pharmacy at KU. Once I completed that program, I wanted to explore the rest of the country for my residency training, and that landed me at UNC Medical Center, where I completed my first year of residency, which was in general pharmacy practice, and then my second year was also at UNC, and that's when I specialized in infectious diseases. Right as my second year of residency was ending, there was a job opportunity at within the Children's Hospital, being the ID and stewardship specialist, and it was just a dream come true that I applied and got the position, and that's where I've been for the past 2 years.
Awesome, thank you so much, Bill. We're gonna go next to Charity Lackey.
Hey y'all, I am a Tar Heel, not born, but definitely bred and hopefully not dead because I've been here for so long. I went to UNC, started here in 2013, finally graduated in 2018 with my bachelor's of nursing. And during my undergraduate nursing degree program, I got into this program called the Hillman Scholars in Nursing Innovation, which is an integrated BSN, which is Bachelor's of Science in Nursing, to a PhD in Nursing Science degree program. So during my first year of nursing school, I also got into the PhD program, and thereafter have been oscillating between both worlds. After I graduated, we have a transition year where you have the opportunity to work clinically. So I worked clinically at UNC Medical Center for about a year on a cancer floor, working with women who have cancer, and thereafter transitioned into becoming a wellness coordinator for the Levine Wellness Distinguished Professor Program, where we program for student and faculty wellness in the School of Nursing. Right now, I am a full-time PhD student with a focus on holistic wellness. Specifically, I study stress and coping in African American women.
Awesome. Thank you so much to our three panelists for your introductions and kind of giving us a little bit of information about where you've been, where your journey up until today. And so I think I would be remiss as a facilitator here, moderator of today's conversation, if we didn't start off the bat with maybe getting some explanations from our professionals on the call about what is COVID-19? So in one way, shape, or form, this was the #1 question that came through on our Instagram post. So we'd love to kind of get a breakdown of what that means.
Sure, I'd be happy to comment on this. So COVID-19 is, or also known as coronavirus disease 2019, is a disease syndrome caused by novel coronavirus that had not previously been described. There are other coronaviruses that are out there that can cause human disease, but they more often cause symptoms like the common cold. And then there's also coronaviruses that only infect animals. While it's not that common, it is possible for animal coronaviruses to cross over to the human species and then spread from human to human. And it's been described 2 other times in our history. The first one was with MERS, or the Middle Eastern Respiratory Syndrome, and the other instance was SARS, or Severe Acute Respiratory Syndrome. It's suspected that, like these other novel coronaviruses, the one that we are currently experiencing originated from bats. Unlike other coronaviruses, we really don't know a lot about this novel coronavirus. So things like, how exactly is it spread? Who's most at risk? What are the typical symptoms? How can it be spread when someone is asymptomatic? These are things that we are all learning about, but it's stuff that we don't know for sure because this is a brand new virus that we're encountering. So as I mentioned, the exact spread is not known, but we have some suspicions, and there's been some evidence to show that it is spread from person to person who are in close contact with respiratory droplets that are produced by an infected individual whenever they cough or sneeze. So the thought is that these aerosolized droplets can then remain in the air and they can be breathed in by those around them, or they might land on another individual's nose or in their mouth, and that's how the disease is spread. As far as symptomology, or symptoms that patients have experienced, there is quite the range, from either being totally asymptomatic, meaning they don't actually experience any symptoms, to having a mild course of maybe some what we consider viral syndrome of a runny nose and a cough, and then all the way to the extreme of patients being hospitalized and requiring different machines to help support their life, and all the way to causing death, as we now know. The last pieces that I'll touch on, similar to other coronaviruses, there aren't any known antivirals or current therapeutics that are effective. There are a number of agents being investigated, but right now the mainstay of therapy is truly supportive care to ensure that patients are adequately hydrated, that they're able to maintain their breathing, and just overall support their life when they come into the hospital.
Did you mute?
Thank you, Bill. I appreciate that answer. I see, Charity, you're unmuting here. Do you want to weigh in as well? Thank you.
Yeah, I just wanted to support the last part, because as with any viral condition, unless there's a vaccine, much of what you're going to be getting in the hospital and at home is supportive care. So I do want to reiterate, things like antibiotics will not help with COVID-19. So I would not be seeking that sort of advice. And if anybody directs you in that way, it is not helpful information. However, I do want to just reiterate the hydration and the supportive care that you need to be thinking about if you do feel symptomatic. So staying hydrated, having like a balanced diet, a colorful plate, those types of things are really helpful in this moment. Even if you are asymptomatic, they'll help with your immune system and with you staying strong.
Right, and I think of a lot of the other kind of topical questions, or a large number of questions came in around, you know, what data is supporting that social distancing is even working. And I know prior to our jump on today, Amy actually had a lot of information to provide about this. Amy, do you want to weigh in a little bit about social distancing and talk to us about what that effect it looks like?
Yeah, absolutely. There are a ton of different people who feel like, you know, they're having to stay home from work. They're having to, you know, basically stay very isolated. So it's important that we tell people like why we know it's working and how effective it is and how much that it actually matters that we do social distancing. So there are two really cool pieces of data that I wanted to talk about. So one of them is this company called Kinsa, which actually gives digital thermometers. They've been doing this for over a decade, I believe. They've been giving digital thermometers. So basically just like you would normally take your temperature, but instead of just recording it and looking at it, it sends those data back to a database that actually the CDC uses, along with a lot of other government agencies. And so there are over 1 million thermometers in circulation that have been used for I think over at least 5 years. And Kinsa has been helping the CDC to track the flu outbreaks across the country. And so now they're using this to say, okay, well, what do we expect is like a normal amount of fever based on what we know about how the flu spreads. And then based on that, like, can we extrapolate all the extra cases, or based on their pattern, are those due to the coronavirus? And so we actually have some really cool data showing that in places that have implemented the social isolation or social distancing policies, they're actually decreasing the amount of fevers that we were seeing compared to a week ago based on these digitally recorded temperatures that people are taking. And there was also a really awesome New York Times article that I wanted to show you guys. Let me try and pull up this link real quick. But what I found was this really awesome image. I'm going to share my screen with you guys so I can show this graph. But what they showed was actually this really awesome image of where people stayed home and where they didn't stay home. So what you can see here is a really great graph of where people didn't stay home during viral spread. So we're using location data from a bunch of different cell phone companies that are reporting like how much people are moving. And we're saying like, are you moving less than you were moving before the social distancing policies were implemented? Or, you know, like at this time last year, this time last week, how much are you moving? So people who are moving basically close to normal, which are the dark red, mean that they're not social distancing, right? Their location is moving all around as opposed to staying in one place, which theoretically is their house. And so you can see this really stark graph kind of showing how many places where people's travel is kind of close to normal, showing that they aren't social distancing. And see a lot of that in the South and kind of the Midwest. And then if you look down at where we're seeing new outbreaks of coronavirus, you can see that basically the places where we aren't seeing social distancing policies are also showing up red on this map. And so that shows that like actually having overlap between implementing the social distancing policies as well as actually seeing the decreased viral outbreaks, that's really, really good indication that social distancing is preventing spread of the coronavirus.
Awesome. We love a good infographic. So thank you so much for sharing that map. I think it helps to definitely contextualize the spread and certainly makes it much more accessible for those of us who this is a really difficult time to navigate what this all means and what the impact really looks like for professionals like yourselves. One kind of last question around COVID, and I'd love to hear more than some of our career-oriented questions, but one of the things that's come up a lot is the mention of general influenza. So could we maybe talk about what the differences are between these two viruses?
Yeah, I can start us off here. So I think one of the main differences that we know about coronavirus versus flu is just the sheer amount of information that we know about influenza compared to this novel coronavirus. We've seen influenza time and time and time again, and so we have a pretty decent idea of what we can expect as far as what types of illnesses does it cause, how is it spread, how is it impacted by the environment, by human behavior. We know so much about the virus itself. All of that is in question when it comes to this novel coronavirus. We have some cousins of coronavirus that we have ideas of how they function, but this is a completely new strain that we are essentially starting from ground zero figuring out. As far as some numbers go, as of today, with the most recent numbers, we have officially reached over 1 million cases of COVID-19 worldwide, with over 40,000 related deaths. In the US, there have been over 200,000 cases of COVID and a little over or just near 3,000 deaths. For comparison, the CDC estimates that there's going to be nearly 39 million influenza illnesses in the United States alone, with over 400,000 hospitalizations and 24,000 deaths just related to influenza this 1 year alone. Now, while the numbers seem quite different, influenza season, as we know it, is tapering off, but we actually are quite unsure of where we are in the process or the season, if we can call it a season, with this novel coronavirus, because we don't know how the environment or the weather will impact coronavirus.
Right, and one of the questions we also got in via Instagram is, when the warmer weather comes, is that going to decrease the spread of this virus? And I think I'm gathering that's a really uncertain answer based off of what you all had shared already. Does that sound about right?
Yep, that's correct.
So essentially what I'm hearing is, because this is the part of the reason why this virus in particular is so scary and so novel for us, is that we don't know enough about it. And because we don't know enough about it, that's slowing our ability to gain access to vaccines and treatments and other resources, which were a lot of our other questions that were coming in, is why do we not have a response yet to this?
And if I can chime in, reiterating what Dr. Wilson is saying about the influenza and the flu that we're more accustomed to, there's a bit of a predictive game that you play with the flu every year. And if you take microbiology 251, Dr. Kramer, she'll tell you about this, where these people, they get together, they look at data, and they try to understand how is the virus mutating, what are different ways that we can adapt the vaccine so that we can have a high prevention rate. And every year that rate fluctuates. I think about 2 years ago, the virus was about 34% effective. And so even with a vaccine, there's still a lot of risk. And that just is something for you to think about, like the influenza that we have known and worked with for decades versus an entirely new novel virus that, like he said, we're starting from ground zero. We don't know how it's mutating. We don't understand it entirely. So creating a vaccine, and essentially, I think we're hitting on, like, it's been going on since around December, January. So I would say it's about 4 or 5 months. So, you know, like we're comparing this to something you've had decades of research on versus 5 months. And then bringing that out further, like in the research world, it takes a while for things to be passed clinically. So you have to try it. You have to see, are there side effects? Are there side effects that we can weigh the scales? Like, are the side effects some that we can just deal with, because what they prevent is that much more hectic. So there's just a lot of games that researchers are having to play with something we don't understand in a very short amount of time, and it costs money to research that. And there are just so many different levels of bureaucracy that you have to go through in order to do that type of research in such a short amount of time. And just thinking about, in the researcher's world, many people are having to immediately stop other projects they might have going on in order to focus on this. So there's just so many different variables that go into conducting the research to come up with the vaccine and to come up with protocol measures to protect other people.
Yeah, and just kind of to build off of that, you know, like a lot of people are worried about, like, you know, not only the bureaucratic hurdles that you were mentioning, but also, you know, like, oh, why can't we just, like, I'm healthy, I'm young, just try me, see how it works. Well, a couple of things, like when you give someone a vaccine, like basically what you do is you give them kind of a part of the virus or a part of something that looks like the virus so that they build up an immune response to that thing. So if their body sees the virus later, they can build up that same immune response again and faster. And so like when you're watching the news and you see all these coronavirus articles, you see this little virus that's covered in little kind of red tags. That's what we're trying to immunize people against. That's actually blocking entry into the rest of the body. So if we all had antibodies floating around, that virus would never be able to get in and infect us in the first place. But when your body gets infected with anything, your antibodies, which are kind of the protection that stays around even after the infection leaves, those don't spike for 2 to 4 weeks after you're exposed to the infection. So what that means is if you injected me with a vaccine and then, you know, you saw my immune response peak 2 to 4 weeks later, okay, that's a month. Then you infected me with a coronavirus. If I were a healthy volunteer getting voluntarily infected, which those are very brave people who are the first people trying out the vaccine. I'm not sure that I would be doing that. And then you follow them again, that's 2 months just to test if this vaccine worked, right? And that doesn't tell you about side effects that could occur 6 months later. That doesn't tell you any of that information. So that's like an 8-week time span to test any single vaccine. That's not the development. That's not manipulating it once you know if it works a little bit. So that time frame is already pretty difficult to work with. The other thing to think about is there are some illnesses where vaccination makes you way, way sicker. And so we just don't know what is going to happen with these new vaccines because, of course, they're new. This is why we do clinical trials. So, for example, in the 60s, we started a vaccine trial to actually vaccinate a bunch of premature babies against another virus that causes cold-like symptoms in healthy children, but in premature children. This virus is called RSV, or respiratory syncytial virus. It causes really, really severe lung inflammation. And so what they saw is actually when these kids got the vaccine, or if they got the virus later, and you would expect a protective response, what you saw instead is that these kids got really, really sick. So it actually made them way worse than if they'd never gotten vaccinated in the first place. And there are stories like this throughout history where actually the vaccination can cause problems on its own. It can cause problems if you encounter what you're trying to be vaccinated against. And so the timing of, you know, the trials, which for any one vaccine take at least 2 months, let alone the amount of time you would need to generate, you know, vaccines that are enough to treat a whole country or the whole world, really make it hard. I mean, we think about vaccine development in terms of like 10, 15 years for an effective vaccine. So it's really, really unique to even have scientists proposing new vaccine like techniques and schedules on such a short notice as like 2 to 4 months.
To put this in a little bit more contextual perspective, if you all remember the Ebola outbreak, vaccinations are just now routinely being distributed. So it certainly takes time.
Can you jog my, I'm terrible at trivia, Bill, so you're gonna have to
I was 14 when it hit. So I was a freshman in high school and we were watching specials about Ebola. So that's 10 years.
Wow, okay.
And so I want to like further contextualizing. So you see this game researchers and clinicians are playing, right? And so that's why we have this social distancing. It's like, so we can contain, it's essentially like, hey, everyone stop, everyone stay home, because we don't really know what's going on and we're trying to figure it out. But if you keep moving around, exchanging fluids with one another, like you're going to like increase the, you're basically going to make everything harder for us. And that can just spiral into another conversation about our healthcare system and what we can actually handle. And that is probably an entirely different Zoom call. But our healthcare system is not designed to handle that.
So we're on April 14th, we'll be chatting with public health professionals who are going to talk about the policy in the public and community health response to COVID-19, as well as kind of their career trajectories as well. So shameless plug for folks watching or watching the recap of this later, April 14th at 2 p.m., same type of setup, but we'll be fully live on Instagram for that one. I think you all have touched on a lot of really good information here. I particularly appreciate the contextualization of how long it takes for us to research and identify a solution to all of this. I think I myself, as a social and human researcher, I think I'm not often thinking about the scientific aspects, and then also the multitude of legal and ethical hurdles that have to be jumped. And then there's the whole political battle, and we here in the US are not dealing with the most streamlined political climate right now. And so it's very interesting, I think, to hear your perspectives on it. One last thing I want to ask and touch on is, we're talking about social distancing. We're having conversations about how we can be good stewards or really be good citizens and not trying to spread this disease for those of us who are healthy or those of us who are symptomatic and staying home and self-quarantine. But what does it truly look like in the impact to healthcare and to hospitals directly if we are to hit this point where we're hearing a lot about, now we're seeing freight liners coming in from the Navy on both East and West Coast ports to expand hospital beds. We're also seeing, lots of reporters having Governor Cuomo come on and talk about his crisis unfolding in New York City and how they're going to navigate and handle that. So could you maybe give us some context about what that looks like on the ground, hospitals exceeding capacity and how that happens and what happens?
Sure. So I think we're quite lucky at the moment at UNC Medical Center in that we've had certainly quite a few rule out cases and just very few cases that we've actually had positive. But we haven't been maxed out from a capacity standpoint. From my peers who are in Detroit, New York City, California, these areas that have been heavily impacted, the hospitals are having to convert their non-intensive care floors into makeshift intensive care units. So now we have a hospital that had, let's say, 50 ICU beds and 400 floor beds, meaning those patients don't require as high of acuity of management. Now all of those floors, not all of those floors, but a good chunk of those floors are now being converted to be more responsive to ICU level care. But just converting the floors isn't enough, because once you convert the floor, you now have to provide the staff necessary that are comfortable with providing that level of ICU care. So some hospitals are able to what's called flexing their staff that have been cross-trained either in intensive care or in infectious diseases. And so they're able to alleviate some of that pressure, but many hospitals just don't have the staff that are ICU trained. And as a pharmacist, I have a number of my peers who have their own specialties. Some might be ICU pharmacists, some might be leukemia or cardiology pharmacists, and they are now being recruited from their primary role to provide care for these intensive care patients just because they need the numbers. So that is what it starts to look like as hospitals are reaching capacity. The last piece that I'll comment is just the amount of supplies necessary to care for these patients and to protect the healthcare workers that are providing care. So from the patient perspective, a lot of these patients who have very significant disease require mechanical ventilation, or essentially there's a breathing machine. Well, hospitals only carry a certain number of breathing machines, and these are not readily available devices. And so it becomes a new ethical conversation of who gets a ventilator and who does not when there is this influx of cases and the hospital is overwhelmed. So that's from the patient perspective. From the healthcare provider perspective or healthcare worker, we use what's called protective personal equipment or PPE to help limit and contain any spread from the patient to me to the next patient that I'm going to go see. And what's really concerning is we are running out of this PPE equipment for a variety of reasons. But what we're trying to do is conserve PPE as much as possible, so that those who need it, meaning the healthcare workers and those who are acutely ill, can help prevent the spread of the virus.
Yeah, and go ahead.
Sorry, go ahead.
Go ahead.
Okay. There's one other thing I wanted to mention. So, if you are visiting patients and you're like, not in a coronavirus situation, if this was a year ago, you would change your gown and change your mask and change your gloves in every single room. So right now we're seeing, because like you have like germs on the outside, right? You have your own germs on the inside that you try to keep to yourself, but anything from your patient is going to be on the outside that you may have come in contact with. Right now, we're lucky if physicians and nurses and support staff in the hospital are able to have one mask on the entire day. Sometimes they're not the right kind of mask. Sometimes, they don't even get to wear masks all the time, and they get one a day, as opposed to, if I was seeing patients last year, I would wear one mask in every room. That's like hundreds of masks a day, right? So that shortage is not only dangerous in terms of the fact that we might lose the support staff that we need to keep the hospitals running and keep taking care of sick people, but it's also dangerous in that we're not being as sterile as we can. We're not preventing, we're not changing basically every time we go talk to a different patient. And so kind of that lack of supplies is driving a lot of the concern. And so people are doing all sorts of things to help kind of keep the numbers of, or keep the amount of supplies we have available. So Duke and a couple of other schools, I'm not sure if UNC has adopted this, but a bunch of universities across the country have different strategies. Duke's basically started an overnight sterilization process. So you pick up your mask in the morning, you drop it off, and then at night it's sterilized and you come back and you use the same one the next day. This is crazy. Like I've thrown away like 30 or 40 of these a day, like previously when I've been working in the hospital. And then the other things, so are that like a bunch of research labs are shut down. I know my lab is shut down. And so we're not doing a lot of experiments. And so most of the time scientists also wear these masks when they work with, dangerous specimens or, viruses or bacteria, things like that. And so we've all donated our supplies to hospitals. So that also makes it harder to keep research going and keep it going if we're giving all of our supplies to the most emergent areas. So that's another reason why it's so important to stay home and prevent the spread of the virus, so that we can try to make sure that everybody has the supplies that they need to help patients who really need it.
And then just to I wanted to talk about from a new healthcare professional perspective, because like he said, there are patients that are having ICU, and ICU stands for intensive care unit. And so when a person gets transferred to an intensive care unit, that means they probably cannot breathe on their own. They have to have hourly checks. Nurses usually only have 1 to 2 patients when you're working on an ICU type floor. And so once you meet certain criteria, the patient can drop down to a step down unit. And so I have some friends that work on step down units, and their units are being converted into ICU style floors. So there's this infrastructure component where, like you said, we don't have enough mechanical ventilators. We don't have enough, you have vital signs that we have to take on the hour, depending on how sick you are. And so you have to have a machine. And some floors that are they're more like medical surge floors is what we call them. They're more of the hospital floors you'll see in Grey's Anatomy on your regular shows. Those are the kind of floors that you see a lot of TV shows talking about. Usually nurses take care of about 4 patients, and you share your equipment because the floor doesn't budget in for a vital sign machine to go in every room. And then alongside with the infrastructure, there's training. So someone who comes out of college, like I did in 2018, and if I were to have gone to an ICU floor, I would have been trained for a year with a preceptor, and I would have learned how to take care of very, very sick people. Now there are new grad nurses who have been working for less than a year who do not work on ICU floors, who are now having to take care of people who are very, very sick in a very short amount of time. So this leaves a whole lot of room for error, medical error, and it leaves a lot of room for hectic conversations on the floor. It is pushing a lot of healthcare professionals to their limits. People aren't taking as many days off, which is where I think my perspective comes in about stress and coping, and how we're going to have to take care of each other during and after this is over, because a lot of people are going to be burnt out, those who stayed home and those who are on the front lines.
Charity, I'm going to ask you to shamelessly go ahead and plug your 2 stress and coping workshops coming up as well.
Yeah, so I'll be talking about yoga and mindfulness for the distraught undergrad on, April 14th. So I'll be teaching, I do yoga, but it's a little bit, I put a little Moss flavor into it. And I also do mind-body skills, so body scans, self-compassion, different ways to work with these 2 systems we have in our body called the parasympathetic and the sympathetic nervous system, and finding ways to bring them into balance. So looking forward to doing that with you all. It's a really great way that I've been using to take care of myself. It's a really good way to decompress your mind from all the screen time that we're having. And it's also just really good to share with your friends who may suffer with anxiety or depression, and they're really intense times.
Cool. It looks like we've got a chat posed in the room to everyone. So anyone here can jump in. The question is, have there been people who could possibly be immune to this virus? I think we'll go to Bill for this.
Yeah, that's interesting. I do not believe that there have been any reports of this at the moment. There are certainly people who are more at risk of complications associated with the virus. Those tend to be our older patient population, as well as those with chronic conditions such as hypertension, lung disease. All patients who are immunocompromised, they're more susceptible to having adverse outcomes with this virus. Whereas when we typically think of viral infections or serious infections, we tend to think of the extremes of age are the most susceptible patient population. But what's very interesting about this particular virus is that is half true. We are seeing our elderly patient population being adversely affected by this by far. But what is super interesting is that our young children and infants, they are having minimal to, if any, symptoms at all if they do become infected. So at the moment, it is unclear why that is happening. But I believe that as time goes on, we'll be able to have a better understanding of, are there underlying hormone levels or antibodies that might be present at a younger age compared to an older age. These are just things that we don't know.
I've seen Amy here too.
Yeah, so I agree with Bill that I don't know of any people that are immune to the coronavirus kind of a priori before they've ever seen it. But for most of the coronaviruses, which coronavirus is actually like the family of viruses that causes a lot of common upper respiratory infections, like a regular cold is usually caused by a coronavirus, not the same one. So if you're immune to, the virus that caused one cold, that doesn't give you immunity to COVID-19, which is one specific coronavirus. But what we know for most of these coronaviruses is that, like I said, the way that you become immune to them is by making antibodies to these proteins on the surface of them. And so if your body has seen the coronavirus, you've gotten sick, part of clearing that virus is making those antibodies. So as long as this, we haven't done these tests in people yet, we just haven't had enough time, and it's not the most pressing issue right now. But I do think that if this behaves like the other coronaviruses, once you've seen it once, you're pretty likely to be immune to it the next time you see it, at least for a while. For most of the coronaviruses, once you're exposed to it once, you're immune at least for a couple of months, if not years.
Awesome. I'd love to work in some of our career-oriented questions in our last 20 minutes here together. And then again, we've got Stephanie on the line still tuned in, so we'll pull her in to talk about resources around job searching and internship searching in healthcare and medical sciences. But I'd love to pose a question maybe first to the group. Could you tell us a little bit about your concentration area and sort of how you decided that that was going to be the area that you wanted to focus on? Let's go backwards for this one. We'll start with Charity.
So that is a difficult question for a current PhD student. So I say broadly, my research interest is the stress and coping experience. I'm just interested in general, what is that? But then specifically for African American women. And so you could just think about who I am and how I present to the world. I am a young Black woman pursuing a PhD at a very young age. I've had plenty of stressors. I've had plenty of different ways of coping, and through understanding my experience and talking to other people, I've recognized that my experience is not the only one, thankfully, but also why. And so my research is looking at, well, what are some of the contextual factors that have led to this very unique stress experience of Black women within the United States and then throughout the diaspora. And then more specifically, I'm really curious about coping. And so it's interesting how like Amy is talking about like antibodies and like what happens when you're exposed to one. And so I'm actually really curious about inflammation and it's this really long word called psychoneuroimmunology. So I'm just basically interested in how is your mind and how you experience the world, how does that affect your immune system, and what are different things that we can do to strengthen our immunity and strengthen our mind so that we have better buffers to the stress that we experience. So that's where all of the mind-body modalities come into play. So that's kind of where I come from. It's a lot of like directed from my experience and then like horizontally supported from how other people have poured into me and said, these are some things you should try. Right. And now I'm supported with research.
I love that. Thank you for sharing. Can you maybe tell us a little bit about, so you graduated from Chapel Hill, and I know you've had a couple different professional experiences. You want to talk a little bit about those prior to joining your PhD program here?
So my professional experience as a nurse was at UNC Medical Center. I actually wanted to work in a NICU, which is a neonatal intensive care unit. And with my scholarship program, you get placed on a unit that somewhat reflects your research interests. So I actually told my program director that as long as there was a baby in the womb, sliding out of a womb, or already out, like I would be fine. And then I got placed on a floor with women who have cancer. So that was quite the turn of events for me. But that experience really showed me, I think, I'm still recovering from that year of working as a new grad nurse. And I think my research assistant position as a student wellness coordinator in the School of Nursing has helped me somewhat find a different perspective and different ways to address some of the issues I saw as a new grad nurse working in a hospital setting.
For sure. Yeah. Thank you, Charity. Appreciate it. We'll go next to Bill. Hey, Bill, hang on one sec here. There you go.
All right. So what initially brought me into pharmacy is really, I thought it was fascinating how much knowledge the pharmacist has. I first experienced that when I was working in a community pharmacy, and the pharmacist was able to answer any and every question that came up. We were in this pharmacy full of different medications, and they knew exactly what all of them did. And so I thought being that resource was really a cool job. And so that's what really turned me to go toward the pharmacy side of medicine. When I got into pharmacy, I pharmacy school, I actually didn't even know that there was pharmacy outside of your community pharmacy, like CVS, Walgreens, etc. And so I was exposed to the hospital world and the specialty world where there are pharmacists who specialize in different disease states. And I'd always had an interest in microbiology. I always thought it was fascinating that there are such tiny organisms that can then overcome such a larger, more complex organism such as a human. And so that was just fascinating to me as well. When I went into residency training, I identified infectious diseases as what I wanted to pursue. One, because it's super nerdy and I really enjoy nerdy stuff, but also no matter what field of medicine you're in, infectious diseases affects your patient population. And what I have noticed in medicine is infectious diseases as a specialty can be quite polarizing. You either love it or you're afraid of it. And so for me as the ID specialist, I can be that resource and be that person that helps my peers and others when they have questions about their own patients. And so just, again, going back to that feeling of being that resource for others and providing answers for their complex patients. That's what I really love about my job, is when people reach out and they're like, hey, I've got an interesting question for you. And then I get excited to help them out.
Thank you, Bill. I appreciate that. Could you maybe talk about any internship experiences or types of experiential learning that you've either participated in yourself prior to coming here to Chapel Hill, or I know you worked closely with Eshelman here as well, and I know they've got a really robust experiential learning program going. So can you maybe talk a little bit about what that looks like?
Yeah, so as part of any School of Pharmacy curriculum, there are essentially on-the-job experiences that each pharmacy student has to go through. As you're going through the first 3 years of coursework, there's a couple, we call them rotations, or experiences, where you essentially get placed in different pharmacy scenarios or healthcare scenarios, and you learn from the pharmacist who has that job. And so you get real, like, on the job kind of training of like, this is what it's like in the field, because you learn so much in school, but not everything translates to everything that you experience in the real world. And then the last year of your pharmacy curriculum is all rotations. And so you spend the entire year out in the field getting an idea of what are the various types of pharmacists that exist and what types of settings they practice in. Sure. Outside of that, I will say a good number of pharmacy students or undergraduate students who are pursuing pharmacy school will work in either a community pharmacy and a hospital pharmacy. There are even veterinary pharmacies. You can work in a nuclear pharmacy. There's so much that you can do. And really just getting that on the job kind of experience is really what will diversify yourself as an applicant if you're looking for pharmacy school applications or residency applications. And then also it just helps you explore what areas you find interesting, if that in fact is the type of career that you want to pursue.
Great. Cool. Thank you so much, Bill. Appreciate it. We're gonna round it out with Amy here.
Yeah, so I started working in a lab during my first year of undergrad at UCLA, and I don't know if UNC is different, but basically the way you find a lab is you just email a bunch of scientists who are on campus and doing something that you think is cool. Charity's nodding, so I think that's a yes.
Like, sure, yeah.
There's not a ton of good, I mean, there are theoretically good resources, but honestly, like, you know, if you know grad students or upperclassmen who are working in labs, talking to them to hear who's a good mentor is a good way to do it. But really you just kind of think like, all right, what sounds cool? And then you email some people 5 or 6 times, and like, as much as you can tell a story about how your undergrad research experience shapes your career, it kind of ends up depending a lot on who replies to your email. And so like, I think especially at UNC and you know, like being at a big school, I was at UCLA, you guys like are in a really unique situation because there's really no other time in your life when you're going to be able to email like 5 of the world's top experts in different things and be like, hey, can I just come work for you for a little bit and see what you do? Like, that's such a great opportunity. So you guys can like, you know, even take this time to just read about who's doing cool stuff on campus that interests you. And so I emailed a bunch of people, but the person that I heard back from worked in multiple sclerosis. Like I said, I was a neuroscience major, so I studied neurodegenerative diseases like multiple sclerosis, Parkinson's, and Alzheimer's disease. And so I started working in her lab actually my freshman year of college. And I basically stayed in the same lab for 4 years, the whole time I was there. And if you ask around, there are ways to get funding to stay over summer. There are ways to, you know, some labs have like research programs to pay you during the year. Because I had a job in undergrad, but like I think for a lot of people, it's kind of, do you have time to work in a lab versus, you know, needing to have a job. And so I think there are definitely opportunities, especially at big public schools, to apply for support that lets you work in a lab instead of just having like an off-campus job. But staying in one lab for a really long time is a super important experience. And I know for a long time, people, like I get questions from undergrads all the time thinking about like, you know, should I do this 3 weeks in each lab experience or like stay somewhere for a whole summer or for 2 years or 4 years? Like, honestly, the best thing you can do is stay somewhere for a really long time, kind of get immersed in it, start to kind of take on more responsibility on your own. And so I was working with my mentor for a really long time. And I think that's a super important experience for both medical school and for a PhD, regardless of what you're applying into. Both of those programs really like to see research on your application.
Right. So essentially, in an ideal world, we're looking at deepening the experience rather than expanding the breadth of experiences.
I think so, yeah. I mean, it sounds kind of tough to say, but like, it's hard to really wrap your mind around a project. Like, I mean, my PhD is 5 years long. It takes a really long time to get really involved in something. And I've had undergrads who've stayed for 6 months, and I feel like they're just barely getting to scratch the surface. I have had students who have worked full time for 2 years, and they still are like, I was just getting the hang of things when they leave, you know? So it takes a long time to get, I mean, the whole point of doing a PhD is to like become the expert in one thing, right? And so you have to be there for a while to be an expert in something, even if you're an undergrad looking for different rotations. But I think that like being you know, there are definitely tracks to apply to grad school and apply to med school and apply to combined programs. But honestly, the best way to do it is to talk to like different professors or upperclassmen who know someone who's just applied, and talk to someone who's just gone through the process. It's honestly better than any of the like advising offices that I've ever been to.
Awesome. Well, we have got a really great resource from our career advising office to chime in and talk about some of our fantastic resources that we have in campus here at UNC Chapel Hill. I want to thank our panelists, all 3 of you today, for spending some time with us. I really appreciate you carving out time. I know all 3 of you are all working and have academic responsibilities. So thank you again so much for carving out time for us. For those watching, we will post ways in which you can follow up directly with each of our panelists if you have more specific questions for them. But without further ado, I'm going to turn it over to my colleague Stephanie here, who's going to talk about university career services and ways in which they can support you in your professional journey towards medical careers in healthcare.
Absolutely. Good afternoon, everyone. Stephanie McIntyre from University Career Services. I'm the Associate Director. I oversee our student-facing team, which are the career counselors who support our students in finding opportunities within your industry and developing the experiences that you need and the competencies to move forward. I want to reiterate what I heard Bill, Charity, and Amy say, that even in the best of times and in cases like what we're experiencing right now, leveraging your professional network, expanding that network, engaging with individuals who practice in the field and in the work that you're interested in. If you have specific research agenda, research interests that are within the health sciences that are aligned with professionals who you can engage with and connect with, and they can become mentors of yours, is really one of the most important components of your career planning and your professional lifestyle. So I just wanted to reiterate that. Just going to take a couple minutes to talk about University Career Services. We are here for all undergraduate and graduate students of the institution. Right now, we are seeing students constantly, virtually throughout the past 2 weeks, and we have capacity for so much more. And so we are spreading the word and making sure that our students know that as you are adjusting throughout these times of uncertainty, we want to continue to be here for you. Our website, careers.unc.edu, you'll see front and center where we have some information that's truly in response to professional development and navigating these waters through the uncertainties of COVID-19. You'll find instruction going through Handshake, which is our career management platform, to schedule that appointment with myself or one of our team of career counselors to speak about things such as your internship and your job search. Over the past couple of weeks, unfortunately, we've heard from a number of students that have talked about disruptions in their job offer or internship opportunity, whether that means that the opportunity was rescinded or if things are shifting virtually. We want to speak to you around your game plan and how to navigate that and how to develop some competencies related to resilience and strong communication skills and managing your professional network so that you can engage with professionals and ask the right questions and then really embark upon your career plan even during these times. Also on our website, you're going to find some very timely and responsive online platforms, our resources that can really help you understand what are some of the trends in the industry and the market right now. So for example, if it is related to health sciences, any of our career counselors can support you in that or direct you to some of our platforms such as Vault, which hosts some very extensive industry guides. We also have an employer relations team who is locking arms with employers and companies and industries throughout industry to understand what are some of the changes in the market and what those changes may be down the road so that our team of career counselors can best support you in your career planning moving forward. So I just wanted to make sure that everyone knows that I am available. Our team of career counselors are consistently available throughout the month of April and beyond. We're going to try some new things. We're going to think of some live Q&A chats. We're going to be offering a few webinars that will constantly be around the job search, internship search, how to navigate communicating with employers during times of uncertainty. So as we secure some dates for that, we will make sure that everyone is aware of that. So I don't want to take any more time, but is there any questions, comments, or concerns or anything that I can answer?
I think we're probably good, Stephanie. And then if we get anything else through the chat feature or through Instagram, I'll make sure to direct them to your office. But thank you again, and thank you to UCS for joining in on this call today with us. For our viewers, stay tuned for more information about our next conversation with public health professionals. So a little bit different than today's conversation about the front lines and the impacts of COVID-19 to our hospital workers and healthcare professionals on the field. But we're also going to now discuss community health and public policy in response to COVID-19, as well as career field and career tracks related to those things. So thank you again so much to our panelists. We appreciate you spending time with us. We always love it when we have a four-legged cameo, so thank you, Charity. Yes, cute. And I'm going to go ahead and end the call. Thank you so much, all of you again. We'll see you later.
Thanks, Jared.